My name is Kalma Kartell White, and I work at the Behavioral Health Training and Education Network as a behavioral health training specialist, and I coordinate the trauma training initiative there, which is in its 18th year. I came to see trauma as an issue at my first job in behavioral health. It was a community, at that time, mental health center in Florida that was serving people coming out of state hospitals with serious and persistent mental illness and trying to help them avoid going back in because they were in the process of sizing down the state hospital. While I was there for 5 years, and during that time, I knew of, I think it was 4 or 5 very young people who completed suicide. And in fact, at least 2 of them had disclosed directly that they had suffered childhood abuse and trauma, and 2 others we had a feeling might have. So that was one aspect. And then there was a young man there. His name was Peter. He was in his mid-20s. And Peter would do things like call up the emergency center in the middle of the night saying, I'm in Lake Worth, which was a town, come and get me, or I'm gonna kill myself, take aspirins, or hit my arm with a hammer. And so he had these suicidal gestures that were not lethal. We had a family meeting with his parents, and what we discovered was that he was the youngest of 3 children by adoption, that his older siblings were married, had children, and seemed to be fine. That he, however, was adopted at about the age of 2. And what the parents were told was that he had been placed in and out of an orphanage pretty frequently from the time of his birth until he was 2 and adopted. And what we saw, we had no idea what to do. We saw that as gross neglect. We couldn't imagine what had happened to him as a child. He was difficult. He was difficult to connect with, but we were able to. And sometimes he would do stuff that was constructive and gratifying, and he didn't seem able to sustain it. He once said in a moment of regular conversation that he didn't understand why he couldn't do positive things more often or more regularly. He showed no signs of intellectual disability at all, but he did behave in a very immature way, a childlike way. So that was a very telling experience, and basically the combination of the 2 factors pushed me off the administrative track that I was on and onto a training track because I thought that would be a better way to make an impact. My interest in trauma was at a time where not a lot of people were, particularly as it related to people with serious and persistent mental illness who were involved in the public behavioral health system. There was some interest beginning in looking at the sequela of childhood abuse in adulthood in the general field of psychology, social work, etc. Since I decided that training was the place for me to go, I started doing a little bit of training while I was in Florida, but in the mid-'80s, I moved to Philadelphia, and I was bound and determined to work for a training entity I had heard about that was long-standing and successful, and eventually I actually did get a position there. Nobody was interested in hearing about trauma. When I had presented it at conferences, particularly this one national case management conference, the people who came were a self-selected group who were in great anguish about what they were noticing and what they were assuming was happening with people, and that these were folks with histories of trauma, and they had no support, and they kind of, when they took it to the administration or supervisors, people kind of said, let's leave that alone since we don't know what to do about it. Or they were not fully believed. They're not believed, but it was similar to a child telling a parent, something bad is happening to me, dad is doing something bad to me, and the mom's saying, oh no, you're not telling the truth. So there was this kind of denial of the accuracy of what they were saying. When I got to the training agency in Philadelphia, I had to figure out a way to bring trauma into a course since nobody was really interested in it as a topic. So I decided to create a course on borderline personality disorder and include the trauma factors that were known at that time. The rooms filled a lot that I went to throughout the eastern half of the state. And what I saw was that I touched people, the course, the material, the information, and people actually started disclosing in class their own experiences. From the beginning, I felt if you're going to talk about trauma and you're going to talk to staff about helping people with trauma histories, you had to talk about support for workers and for staff and for clinicians because of the risk they were facing and the vulnerability they had to things like vicarious trauma, which could be caused by hearing traumatic details from people they were trying to help. There's a whole literature on it and research on it. Yet, the work has to be done. The helping needs to happen. Basically, after that, I was able to create a course in post-traumatic stress disorder at this first training agency that I worked at. And at conferences, we were doing conferences on co-occurring mental illness and substance abuse. And I urged that they get some trauma experts in with the idea that trauma was a co-occurring problem. They didn't call it co-occurring disorders at that time. They called it co-occurring mental illness and substance abuse. So that allowed some people to deliver information to the system, those who came to those conferences. In 1998, I changed jobs and went to another training agency, the one I'm at now, the Behavioral Health Training and Education Network. The reason I had to do that was because my husband was very ill and I could no longer travel. I had a young son. And when I got to the new agency, BH10, they basically asked me to coordinate a special training project to train behavioral health staff in how to work with women who were being impacted by welfare reform, if you remember welfare to work. And what was being found was that at least 25% of them had histories of sexual abuse that did not allow them to really comply with the demands of the reform. It was an interagency, cross-systems effort. And the good news out of that, aside from the fact that we were introducing more about trauma, was that eventually I was kind of able to leverage this effort into a long-term behavioral health trauma training initiative. The reason being, in large part, the director of mental health at that time was Estelle Richmond. She was very aware of the impact of trauma. We had also had a number of symposia, about 3 years in a row, where we had brought in national experts on trauma and domestic violence in order to kick off the Welfare to Work project. And we marketed these meetings to administration and management in DBH and provider agencies. And at the end of those, we were told by one of the administrators in DBH, we really have to do something about this. And they gave us a very tiny pot of money, and we began presenting an annual series of foundational training about trauma, being trauma aware, being trauma informed. And we were also able to actually introduce what was probably the first intervention for working with survivors of trauma, which was the Trauma Recovery Empowerment Model. It's an evidence-based model that was developed at Community Connections in Washington, D.C. by Maxine Harris and her staff. So we've been presenting that for, I would say 12, 13, maybe 14 years. We have not gotten, up until Dr. Evans came, we didn't get big system support. We did have that pot of money. That was a big deal. But people were not real interested in the TREM, for example, which needed extra support for workers because 2 staff were required to facilitate each group, and fee-for-service made that very difficult. But at least people were learning about how to talk to people about their trauma experiences and how to help them deal with the impact of the experiences rather than treat the symptoms, if that makes sense. I think it's important to mention that in 2005, we've been going since 1998, but in 2005, Dr. Arthur Evans came to Philadelphia as the Director of Behavioral Health and now the Commissioner of the Department of Behavioral Health, and he brought with him an agenda that included recovery from severe persistent mental illness was possible and to be facilitated, and his agenda included addressing trauma among folks with those behavioral health challenges. And that was wonderful because it opened people up even further to hearing about trauma. And then the reality is that Philadelphia began offering some trauma-specific training and some trauma-informed training. Sanctuary model was offered as trauma-informed, and trauma-focused cognitive behavioral therapy for children has been offered for training, as well as prolonged exposure. So there's a beginning of doing both trauma-informed support work, dissemination of how to be trauma-informed, as well as specific interventions for people to be able to do at least some treatment of individuals with those histories. By and large, it was the luck of the draw on some level, having somebody at the top of the mental health department who was trauma aware. And she was lucky because there were a couple of us who really were aware as well. So if she had vision and concern, we could do something about it. I was kind of told that I was overreaching by trying to push for this trauma initiative, and but I went ahead anyway. And again, it was luck. It was. I had an interest. I had done my reading. I had learned a lot, and was lucky enough to be in a place where something could get done. In the sense that the Trauma Training Initiative, we've trained, I'm not sure of the exact number to date, I would say about 10,000 people over this 18-year period. Some of them are probably not even in the system anymore. So we've gotten it out, and what I believe we've contributed to is seeding the system and making people are now aware of trauma as an issue and trauma as a factor. And that has caused, I believe, some change in the culture. And the best example that I had of this was I've been doing an orientation session for new case managers working with adults, probably for about 15 years at least. And when I began doing that, I began to talk about trauma as a co-occurring problem. I was doing something on mental illness and substance abuse, and I added trauma to it. And I would use a case example in which I would ask people, what would you tell this person to do if you could to help themselves? And I got all the standard answers that were about control and put them in a 24, kind of cookie cutter answers about what you do with somebody who doesn't have control of their life and who is frequently in the ER, the psych ER, or in a crisis, I don't remember what they call it here, in the psych emergency services. they would give all of the stock answers of the time, and then we'd talk about it. They knew she had an extensive history of trauma, and then we discuss it. I think the biggest challenge was engaging staff so they didn't feel defensive, because what I was trying to do was help people not cause the harm that was in fact inadvertently being caused to people in the system because of insensitivity to the trauma sequela that they were living with. So that went on for a while, and then about 3 or 4 years ago, I put out the same case example. And for the past 2 years before that, I've been getting maybe 1 or 2 trauma-informed responses. Well, this one session, I got 20. And I tried not to let my jaw drop, but it was probably one of the best moments of my work life, was to see that somehow it was in the culture. And I don't believe that we did it all, but I think we contributed very much to seeding the system. And then I believe that Dr. Evans' increasing attention to trauma also helped. But it didn't take overnight. New ways of approaching treatment and services can take up to 15 years to reach the trenches. So even though there's a high amount of awareness in the federal government and in the city Department of Behavioral Health, it's taken a while to reach the trenches. Now what has to happen is a much more broad-based set of alternative strategies, trauma-informed tools for people to use. And more people have to be reached than we were able to. I really think that training doesn't fix everything, but I think you have to start with education. The stigma that is entrenched in the behavioral health field is pretty heavy duty, and that's in the literature. So you really have to be able to engage staff and offer them information that they can hear and accept, and then provide them with some tools that they can use to actually change how they are relating to the people they serve. You have to start, the top has to have a buy-in. If you just go to line staff, it is not going to be effective. I feel very much that we were limited. We were both blessed because we had upper administration support, but we were limited because we didn't have sufficient access to training middle management. And I believe that whatever you do, whatever people do, whether it's a pilot project that you do a cross-section in terms of the training in being trauma-aware and being trauma-informed. You can't expect to have, I believe, and from what I've read, you can't expect to have successful trauma-specific interventions and treatment without agencies and the system being trauma-informed. One will work against not being trauma-informed will work against the treatment, will work against people being referred if treatment is made available. What helped us, I think, was, I don't remember if I mentioned this, were the 3 symposia that we were able to present at the beginning of the initiative. We had national experts come into Philadelphia to speak 3 years in a row, different people who were doing research, treatment, who were trauma experts, including Sandy Bloom, including Carol Tracy, who's a tremendous advocate here in Philadelphia. And in terms of domestic violence, we got people from Chicago, from Northeast. We actually got Maxine Harris from Community Connections to come and speak. And I think, and very importantly, we got somebody named Karen Suck-Whitney to talk about vicarious trauma. And these went over very, very well. They were extremely informative. We were kind of using the bring the national experts in approach. And I really think that helped launch a great deal. You almost have to take a multifaceted approach. I believe the community, there needs to be an effort. I believe also that people with lived experience of trauma, people in recovery, their family members need this education. this information through parent supports and groups. It's important for parents to learn a little bit about how to respond to their loved ones who may be responding to their early traumas. Obviously, engagement and tact are important. And also the community. With the degree, the ACEs study, which I'm sure somebody else will go into, has revealed that in an urban area like Philadelphia, the adverse childhood experience scores are higher than they were for people in the initial study in San Diego. And 5 different categories of ACEs were identified. And because of that, it was I'm not going to remember all of them, but racism, bullying, community violence, I can't remember the other 2. But it's very clear that people in our country are having problems with trauma, that it's just not an issue with people who have mental illness or mental health problems or substance abuse problems, where it's huge as well, that all of us have some experience with trauma, some of us more than others, and some of us have this ongoing. And so I really think systems need to be educated into how to integrate trauma-informed practices into what they do. And that's been started in Philadelphia among the police. Some stuff has started among education. And across the country, I think there are efforts being made to address being trauma-informed and trauma-aware in different areas of the community. But I believe community leaders and community networks and neighborhoods, it would be wonderful if they could be given the information and some strategies that they could use with each other that are not clinical, that are about, for example, helping people calm the trauma response. There are specific things that can do that are not clinical. So I think a multifaceted approach is what it's about, because it's about prevention, basically. You want to do prevention at the earliest possible time. Sometimes you can't prevent exposure to the trauma, particularly in an urban area, but you can through schools, primary medicine, and other community entities provide trauma-informed care and referrals, if necessary, if people need help to cope with what they've experienced. I think it started to some extent. I'm not totally familiar with it, but there is an effort being made to train the entire system about trauma and being trauma-informed, the behavioral health system. And there's also a number of different entities, I think, are starting to provide education to primary care medicine, to the schools. And I hope and I believe it is the intention of the Department of Behavioral Health to move into community education and engagement of community leaders. One of the things that we've been doing is mental health first aid, which is something that helps lay people, neighborhood folks, help each other, friends, neighbors, etc. And I think that needs to become more trauma-informed, and in fact has. It was sort of put together before being trauma-informed was deemed as essential as it is now. It would reduce the harm in behavioral health that's inadvertently done to people with lived experience of trauma, because folks would know how to engage folks in a way that was supportive, respectful, with dignity. And with the education provided to the people coming for services, it would give them what they need to figure out what will work best for them to help with the trauma symptoms and trauma signs and difficulties that they may have. In education, that is crucial. We are harming kids tremendously in schools with the disciplinary actions that are taken, with kindergartners are being suspended, for goodness sake. where changes are now being made, children are being communicated with, where things are beginning to work, and ask what's happening that you're doing this stuff or behaving this way, in child language, of course, child-centered language. And some of the schools are finding, lower and upper schools, that the suspension rate has gone down, that more kids are attending more. So I would want to see that implemented. I would want to see the kind of co-location that's been discussed and is happening of behavioral health staff at primary care locations, particularly public health locations, so that they're in a position, if somebody discloses domestic violence or concern about trauma, to immediately speak with that family and see if there's anything that they can do to help or any place they can refer them to. I think I'd like to see the last vets out from under the bridges, and I believe that what has fed that situation is that people who went to war, many of which suffer from post-traumatic stress disorder, but many of which could recover. I think there is a significant percentage of those folks who had childhood trauma that just combined with their combat experiences, and they were unable to cope, and the usual treatment didn't touch it. So I would hope to see nobody under the bridge, including other homeless people, because trauma drives homelessness as well. In addition to finances, trauma is not the only thing that drives homelessness. Not having money does also. But once out there, the amount of trauma that somebody suffers is huge. So there are a whole bunch of things: sufficient housing, police being trained to not hurt people, to not shoot first and ask questions later. Their trauma needs to be dealt with. Some of how they behave comes from what they've seen and experienced, both in terms of primary trauma themselves, how many times, what they've seen in terms of what people do to each other, and how close they've come to losing their lives. So I would like to see that continued. What have I left out? Every system, I would hope to see be educated in the impact of trauma. And I believe that neighborhoods, faith-based communities, faith entities, community groups, community recreation centers, places where there are community activities, need to have at their disposal ways to educate about trauma and help people who are having reactions. I think that begins to be a trauma-informed city. And finally, but not least, criminal justice. Sending children to jail for possession, for nonviolent crimes, and then creating a traumatized population of kids who've been in jails. The adults who go to jail for real live crimes, the amount of trauma that they have in their backgrounds is huge. I don't suggest that they not, that people not pay the price for violent crime and robbery and the kinds of crimes that impact others. But I do believe that it's possible for folks to change and take advantage of being where they are to learn about trauma and its impact on them. The numbers are huge in terms of the impact of trauma on inmates in prisons, men and women, both, so that you would have less recidivism. If prisons were less less traumatic, that would help. If there was a sense of real people can rehabilitate, that would help. It's costing us huge amounts of money. We must put prisons back in the public sector. I think there are terrible things. It's in the press. We're hearing research about it. There are terrible things happening to both people sent to prison, people coming out of prison, that has to be addressed. And trauma interweaves with all of that.